Good evening, and welcome to our broadcast. Tonight, we delve into an exceptionally challenging and sensitive subject: the question of whether it is sometimes necessary to mandate medication for individuals experiencing severe mental illness. This is a topic that sits at the complex intersection of medical ethics, human rights, and compassionate care. It forces us to confront difficult questions about individual autonomy versus the responsibility to protect vulnerable individuals and society. To help us navigate this intricate debate, we have two distinguished guests. Dr. Ben Carter, a psychiatrist, will argue for the necessity of mandated treatment in certain, carefully defined circumstances. And Ms. Anya Sharma, a human rights lawyer and mental health advocate, will present the arguments against such measures, emphasizing patient rights and alternative approaches. Welcome to you both.
Thank you, Sarah. It's crucial to begin by acknowledging the profound ethical considerations we are discussing. The idea of mandating any medical treatment, particularly in the realm of mental health, is not something anyone approaches lightly, and it demands rigorous debate. However, in my clinical experience as a psychiatrist, dealing with the most acute phases of severe mental illness, there are, regrettably, specific and severe circumstances where mandated medication becomes a necessary, albeit last resort, intervention. We are not talking about a broad application, but rather a very small, specific subset of individuals, often those with conditions like schizophrenia or acute phases of bipolar disorder. A key factor in these challenging situations is often the presence of anosognosia. This isn't simple denial. It's a neurological symptom of the illness itself, which means the individual genuinely lacks insight into their own condition and its severity. They are, in effect, unable to recognize that they are ill or that their perceptions and judgments might be impaired by their illness. When this profound lack of insight is coupled with a clear, present, and substantial risk of significant harm, perhaps to themselves, through extreme self-neglect, leading to medical compromise, or a demonstrable risk to others due to delusions or hallucinations directly influencing behavior, then the ethical calculus shifts considerably. We must carefully weigh the potential for irreversible consequences if we fail to act decisively and compassionately. It is absolutely essential to stress that mandated treatment should only ever be contemplated when all other less restrictive options have been thoroughly attempted and have failed, or are demonstrably inadequate to meet the acute and urgent needs of the patient. This includes persistent efforts at voluntary engagement, comprehensive community support services, and a variety of therapeutic approaches tailored to the individual. The primary objective of such an intervention is not, and should never be, to control or punish an individual. Instead, the aim is to alleviate profound suffering, stabilize their acute condition, and ultimately to restore the individual's capacity for autonomous decision-making. By treating the underlying illness that significantly clouds their judgment and perception of reality, we aim to bring them back to a point where they can once again make informed choices about their own life and ongoing care. Ultimately, in these carefully delineated and legally safeguarded situations, mandated medication can be a life-saving measure. It can prevent tragic outcomes such as death by suicide, severe physical deterioration from self-neglect, or unintentional harm to others. And it offers a crucial pathway towards recovery, stability, and the regaining of a meaningful life.
Thank you, Sarah. While I appreciate Dr. Carter's perspective and his emphasis on difficult cases, I must begin by firmly centering this discussion on fundamental human rights: the right to bodily autonomy, the right to make decisions about one's own medical treatment, and the principle of informed consent are cornerstones of a just and ethical society. Mandating medication, by its very definition, involves overriding these fundamental rights. It is a coercive act, and coercion in the context of healthcare is fraught with peril and carries a heavy historical burden, particularly in mental health. We must seriously consider the significant risks associated with such mandates. Firstly, the risk of misdiagnosis is real. Psychiatric diagnosis, while advanced, is not infallible. Forcing medication based on a potentially incorrect assessment can have devastating consequences for an individual's physical and mental well-being. Secondly, the very act of forced treatment can be profoundly traumatizing. It can lead to a deep-seated fear and mistrust of mental health services, making individuals less likely to seek voluntary help in the future, even when they might be open to it. This erosion of trust is incredibly damaging to long-term recovery prospects. Furthermore, psychotropic medications, while beneficial for many, can have severe and sometimes irreversible side effects. To impose these risks on an unwilling individual, who may have valid reasons for their refusal based on past experiences or personal values, is a serious ethical breach. Instead of focusing on mechanisms of coercion, I believe our efforts and resources should be channeled into strengthening voluntary, person-centered alternatives. This means investing in robust community mental health services, assertive outreach programs that build relationships, peer support networks where individuals with lived experience can offer guidance, and fostering therapeutic alliances based on trust and mutual respect, not power dynamics. True recovery is built on empowerment and collaboration. It is about providing individuals with the support, understanding, and options they need to navigate their mental health journey, not compelling them down a path they have not chosen.
Dr. Carter, the principle of primum non nocere, first, do no harm, is absolutely central to medical ethics. How do you reconcile this fundamental principle with an intervention that explicitly overrides a patient's expressed wishes, especially when, as you've mentioned, they might lack insight into their condition due to the illness itself?
That's a critical question, Sarah, and it lies at the heart of this ethical dilemma. The concept of harm in these specific situations is multifaceted. While overriding a patient's expressed wishes can be seen as a form of harm to their autonomy in that moment, we must also consider the harm that results from inaction. Severe mental illness, particularly when accompanied by psychosis or profound anosognosia, can intrinsically compromise an individual's true autonomy and their capacity for rational decision-making. The illness itself effectively hijacks their ability to perceive reality accurately and to act in their own best interests. In such cases, allowing the illness to progress untreated can lead to devastating harms. Severe deterioration in their mental and physical health, extreme self-neglect, homelessness, and increased risk of suicide or unintentional harm to others. This inaction in itself can be a failure of our duty of care. Therefore, the intervention, while undeniably difficult and involving a temporary overriding of expressed wishes, is aimed at mitigating these greater, potentially irreversible harms. The ultimate goal is to treat the underlying illness that is impairing their judgment, thereby restoring their true autonomy and their ability to make informed decisions once their thinking is clearer. It's about enabling a return to self-governance, not imposing long-term control.
Dr. Carter presents a compelling argument from a clinical perspective, and I acknowledge the genuine distress and difficulty these situations pose for clinicians and families. However, the determination of, quote, lack of insight and what constitutes a patient's, quote, best interests is often far more subjective and open to interpretation than we might like to believe. Who decides when insight is sufficiently impaired to warrant such a drastic measure? While anosognosia is a recognized symptom, its assessment can be complex, and there's a risk of conflating it with a simple disagreement with medical advice or a different cultural understanding of mental distress. Furthermore, the potential damage to the therapeutic relationship from coercive treatment cannot be overstated. Their sense of self and agency can be profoundly undermined. I must reiterate the absolute importance of exhausting every conceivable, less restrictive option. This means creative, persistent, and culturally sensitive engagement, peer support, advanced directives where possible, and a genuine exploration of why an individual might be refusing treatment, rather than immediately defaulting to a conclusion of impaired capacity. A paternalistic approach, however well-intentioned, risks disempowering the very individuals we seek to help.
Ms. Sharma, your points about autonomy and the risks of coercion are very powerful. However, let's consider those acute crisis situations where an individual, due to untreated severe psychosis, is demonstrably and imminently a danger to themselves or others. If all genuinely voluntary efforts have been exhausted and have failed, what is the alternative? Are there societal concerns about the practical implications and community safety if mandates were never an option in any circumstance?
That is, of course, the most challenging scenario, Sarah, and one that evokes strong emotional responses. When we speak of, quote, danger, it's crucial that this isn't based on speculation or societal fear, but on clear, objective evidence of imminent risk. However, even in these situations, I would question whether our current systems truly and exhaustively explore why voluntary engagement has failed. Was the engagement culturally appropriate? Was it persistent enough? Were all available community supports mobilized effectively? Sometimes, what is perceived as failure of voluntary treatment is actually a failure of the system to provide adequate, accessible, and trustworthy care that meets the individual's specific needs and circumstances. Even with proposed legal safeguards, mandated systems are inherently fallible and prone to systemic biases, whether based on race, socioeconomic status, or other factors. The power imbalance between the state or medical authority and the individual is immense. Such systems can be, and have been, misused. Moreover, there's a genuine concern about a potential slippery slope. If we accept mandated treatment for a narrowly defined group, there's a risk that the criteria could gradually expand, leading to broader application and a further erosion of rights. The focus must remain on improving voluntary care to prevent crises, rather than relying on coercion as a backstop.
Ms. Sharma raises valid points about systemic issues and the potential for bias, and I absolutely agree that our systems of voluntary care need continuous improvement and investment. No one desires a system that is overly reliant on coercion. However, to suggest that mandates should never be an option, even in the most extreme circumstances of imminent danger where all else has demonstrably failed, presents its own profound ethical and practical problems. Robust legal frameworks, such as those involving judicial oversight, the right to legal representation for the patient, regular reviews of any mandate, and decision-making by a multidisciplinary team, not just one doctor, are essential to mitigate the risks of misuse and bias. These safeguards are not perfect, but they are designed to ensure that such decisions are made with extreme caution and scrutiny. The alternative, knowingly allowing an individual to suffer severe preventable deterioration, to die by suicide, or to cause serious harm to others when effective treatment is available but refused due to impaired insight, is also ethically problematic and, frankly, can be seen as a form of societal neglect. It places an immense burden on families and communities as well. These decisions are never taken lightly. They involve extensive consultation, ethical deliberation, and a deep sense of responsibility. The goal is always to protect and restore the individual, and to ensure public safety when that is a genuine and immediate concern directly linked to the untreated illness. In closing, I want to reiterate that from my perspective as a clinician who has witnessed the devastating impact of untreated severe mental illness, mandated medication, while a profoundly serious step, can be a necessary and, indeed, compassionate tool in exceptionally limited and clearly defined circumstances. This is not about widespread coercion or convenience. It is about those rare, tragic situations where an individual's illness has so completely overwhelmed their capacity for insight and rational decision-making that they are on a path to severe harm or even death, and all other avenues of help have been exhausted. In these specific instances, carefully applied and legally safeguarded mandated treatment should be viewed not as a punishment, but as a pathway to alleviate profound suffering, to stabilize a crisis, and to offer the individual a genuine chance for recovery and the regaining of a meaningful life. a life where their own voice and autonomy can be restored. The ethical challenges are undeniable, and we must continue to debate, research, and refine the safeguards surrounding such interventions. However, an outright rejection of this option would mean abandoning some of the most vulnerable individuals in our society when they are at their most desperate and incapable of helping themselves. Our duty of care demands we keep this difficult option available, under the strictest possible controls.
As we conclude, I must reaffirm the paramount importance of the right to bodily autonomy and informed consent as fundamental human rights. These principles must be the bedrock upon which our mental health care systems are built, not exceptions to be easily overridden. While Dr. Carter speaks of compassion, we must also acknowledge that compassion cannot exist in a vacuum devoid of respect for individual liberty. The profound risks of diagnostic error, the potential for abuse within systems of power, and the re-traumatization inherent in coercive practices are too significant to be treated as mere procedural hurdles. They represent real harm to real people. Our societal focus and investment should be directed towards creating comprehensive, well-funded, and easily accessible voluntary mental health care systems. These systems must prioritize building trust, empowering individuals, offering a diverse range of therapeutic options beyond just medication, and ensuring that care is culturally sensitive and person-centered. Recovery from mental illness is a deeply personal journey, and it is best fostered through support, understanding, and collaboration, not through compulsion. By upholding the rights and dignity of every individual, even in the face of severe illness, we create a more just and truly compassionate society that offers hope and genuine pathways to well-being for all.
Dr. Carter, Ms. Sharma, thank you both for your incredibly insightful and thoughtful contributions to what is undeniably a very challenging and multifaceted discussion. Your distinct perspectives have truly illuminated the complexities involved. It's clear that balancing the imperative to provide care and ensure safety with the fundamental rights and autonomy of individuals with severe mental illness will continue to be a subject of critical debate and societal reflection. Thank